Here is our roadmap. We are covering pleural diseases and empyema, managing massive hemoptysis, lung cancer staging, pleural and mediastinal tumors, lung transplantation essentials, and finally, perioperative thoracic care. Let's get right into it. Section 1, Pleural Diseases and Empyema. Look at this X-ray. See that clear separation of the visceral and parietal pleura on the left side? That is trapped air. The classic textbook case you'll see here is a tall, young guy showing up with sudden shortness of breath and chest pain, usually from a ruptured apical bleb. Now, here is the absolutely crucial number you have to commit to memory. If you manage this conservatively without surgery, there's a 50% risk of it happening again on that exact same side. And if it happens a third time, that recurrence risk skyrockets to 80%. Because of that massive recurrence risk, our management step-up makes a lot of sense. For healthy patients with small, asymptomatic leaks, we just watch them and give supplemental oxygen. Why oxygen? It actually changes the nitrogen gradient and helps reabsorb that trapped air. Now, if the leak is larger or they are symptomatic, we step it up to aspiration or a tube thoracostomy, which is your absolute gold standard for big air leaks. But if it keeps coming back, if it's bilateral, or if that air leak just won't quit after 3 to 5 days, we bring in the big guns. We escalate to VATS, video-assisted thoracoscopic surgery, to actually go in, mechanically resect those blebs, and do a pleurodesis. Now, what if the chest is filling with fluid instead of air? That is where a thoracentesis comes in. This diagnostic algorithm is a real game changer because it instantly splits your patients into 2 totally different pathways using Light's criteria, which looks at the LDH and protein ratios in the pleural fluid. If it's a transitive effusion, it's a secondary issue caused by backed-up intravascular pressure. Think congestive heart failure or cirrhosis, and you just treat that underlying cause. But if it meets the criteria for an exudative effusion, you're looking at increased vascular permeability. That points you straight towards things like pneumonia, empyema, or a malignancy. Moving right along to Section 2, Managing Massive Hemoptysis. We are moving from the pleural space straight into the airway for a major clinical nightmare, massive hemoptysis, or coughing up huge amounts of blood. The most important thing to grasp here, this isn't just a bad symptom, it is an absolute drop-everything surgical emergency. Here's the thing, these patients usually don't bleed to death, they asphyxiate. So step 1 is totally non-negotiable. You secure that airway. Only after the airway is locked down do you move to step 2, which is getting a bronchoscope in there to find out which side is bleeding so you can protect the good, healthy lung. Once you're actually in the airway, there's a strict hierarchy of interventions. And keep this high-yield fact in mind. The bleeding almost always comes from the high-pressure bronchial circulation, not the pulmonary circulation. You try to control it first with topical vasoconstrictors or a balloon catheter. If that doesn't work, angiographic embolization of the bronchial artery is your next best move. It's fantastic because it lets you salvage the lung without cutting anything out. You really want to save a thoracotomy and lobectomy or pneumonectomy as an absolute last resort, simply because the surgical risk is just incredibly high. Section 3, Lung Cancer Staging. Let's pivot into thoracic oncology and contrast the 2 major classes of lung tumors. On one hand, you've got small cell carcinoma. This makes up about 20% of cases. It's highly aggressive, centrally located, and by the time you find it, it's usually spread way too far for surgery. It is, however, highly responsive to chemo right out of the gate. On the other hand, we have non-small cell carcinoma, which makes up the other 80%. This includes your adenocarcinomas and squamous cell variants. These are the patients who make up the vast majority of our actual surgical candidates. Now, those non-small cell carcinomas often show up first as a solitary pulmonary nodule, just like you see here in the right upper lobe. When you're looking at a nodule like this, you're hunting for clues. If it hasn't grown in 2 years and has popcorn calcifications, you can breathe a sigh of relief. It's likely benign. But if you see irregular borders, eccentric calcifications, or it lights up with IV contrast, that heavily points to a malignancy. You absolutely have to follow that up with a PET scan to check for metastasis and then get a definitive tissue biopsy. Once you have the diagnosis, getting the staging right is everything. Take a look at this AJCC staging table. See how the 5-year survival rates completely dictate our surgical approach? Stage 1 and Stage 2 patients have localized tumors with no distance spread. They are prime candidates for an anatomic lobectomy, and their survival rates can hit up to 80%. But watch what happens as we move down the list. By the time you hit Stage 4, which means there's distant metastases, the tumor is generally unresectable, and that 5-year survival plummets to a heartbreaking 2%. Section 4, Pleural and Mediastinal Tumors. Stepping outside the lung itself, we need to talk about malignant mesothelioma. This is a terrifyingly aggressive cancer that is directly tied to old asbestos exposure, often with a latency period of literally decades. Patients usually show up with vague chest pain, weight loss, and pleural effusions that just keep coming back. Because it's so aggressive, you can't just do surgery alone. You have to hit it with a massive multimodal approach, a brutal combination of chemo, radiation, and a huge surgery, often an extrapleural pneumonectomy. That literally means taking out the entire lung, the pleura, the diaphragm, and the pericardium on that side. It is a massive deal.
When we look at mediastinal masses in general, it really helps to build a simple diagnostic framework. We categorize these tumors purely by where they sit relative to the heart on a lateral chest X-ray. In front of the heart, anterior. In the same compartment, middle. Behind it, posterior. It sounds simple, but memorizing these buckets is a massive shortcut. It lets you instantly narrow down your differential diagnosis before a biopsy needle ever touches the patient.
And for that anterior compartment, you absolutely have to know your terrible T's. If you spot an anterior mass, your brain should immediately jump to thymoma, teratoma, aberrant thyroid tissue, and terrible lymphoma. You want to pay special attention to thymoma. About 15% of patients with myasthenia gravis actually have a thymoma. And remember, these are staged using their own specific system, the Masa-Oka system, which relies on capsular invasion to figure out the prognosis and the treatment plan.
Section 5. Lung Transplantation Essentials. All right, let's pivot from removing diseased tissue to totally replacing it. Lung transplants are usually reserved for terminal, irreversible diseases, things like COPD, idiopathic pulmonary fibrosis, and alpha-1 antitrypsin deficiency. Now, surgeons can do a single or a bilateral transplant. Single lungs are great because the ischemic time is shorter and you can help 2 patients with 1 donor. But look closely at cystic fibrosis on this list. CF is an absolute non-negotiable indication for a bilateral transplant. Why? Because if you leave 1 native CF lung in there, it's essentially a reservoir of chronic bacteria that will immediately cross-contaminate and destroy your brand new immunosuppressed lung.
Finally, Section 6. Perioperative thoracic cow.
Listen, you can pull off a technically flawless thoracic surgery, but it means absolutely nothing if the patient doesn't survive the ICU. Thoracic post-op care is a whole different beast compared to abdominal surgery. You have 2 non-negotiable rules here: aggressive pain control and strict fluid restriction. First off, a thoracotomy is quite literally one of the most painful incisions in surgery. If your patient is in agony, they won't breathe deeply, which leads to atelectasis and terrible pulmonary toilet. We use routine epidural anesthesia to fix this. Second, you have to run these patients dry. If you over-resuscitate a thoracic patient with IV fluids, you can easily trigger catastrophic pulmonary edema in that newly re-expanded lung. We will often happily accept a temporary drop in urine output if it means protecting those lungs.
So we have just powered through a massive amount of high-yield thoracic data, but I want to leave you with something to think about. Based on all these foundational principles, how do you think the explosion of minimally invasive VATS paired with hyper-targeted stereotactic body radiation for our poor surgical candidates is going to rewrite those survival rates over the next 10 years?